Okay, good morning. Welcome to the UCLA HIV Grand Rounds. My name is Dr. Lejeune Lockett from Charles Archer University of Medicine and Science, Office of International Affairs, and I'm very happy to introduce the speaker for today. We have one of our colleagues who's here from South Africa that collaborates with the project's work that we're doing in Zambia, and he will present on his topic related to the work that's being done there. If I can just give you a brief introduction. Just one second. Okay. He has an extensive bio, obviously, so I think we can probably get that information out to you virtually. But what I'd like to do now is to introduce Dr. Henry Fomundam to you. He's a regional director of Howard University Global Health Initiative. He graduated from Howard University, Washington, D.C., with a doctorate in pharmaceutical care and did a postdoctoral fellowship certificate in public health, National School of Public Health in Medunsa in South Africa. He has over a 30-year career working in the areas of HIV, AIDS, TB, medicine regulation, pharmaceutical care, global health management, and academia in the United States and several African countries. He has been an associate professor for over 19 years at Stellenbosch University, an African Center for HIV and AIDS, and has given several lectures at Howard University Pharmaceutical Care and Public Health, as well as Monash University in Public Health in South Africa. Working for Howard University for the last 20 years, Dr. Fomundam has been the PI for 8 PEPFAR-funded projects for Howard University, covering 14 countries in Africa. Since 2005, Dr. Fomundam has been the regional director for Howard University Global Initiative. He is the current PI for Howard University, component of the Public Health Practice Transformation Project in Zambia, focusing on high-volume facilities in Lusaka, Southern, and Copperbelt provinces since 2017. He was also a member of the Institute of Medicine, the IOM team, that evaluated the initial $15 billion that was approved by the U.S. Congress for HIV/AIDS prevention, treatment, care, and support in the 15 high-burden countries, with 12 of them being in Africa. With this, I would like to bring Dr. Fomundam to the podium. Thank you.
Can you hear me? Well, good morning, everybody, and thank you very much, Dr. Lockett, for the introduction. Let me start by thanking UCLA for inviting me all the way from South Africa, and especially thank Rena for all the correspondences, and thank our CDU colleagues for facilitating this. But let me start by making a few remarks, which are not, they are my remarks and not that of my institutions or any of the collaborating institutions. The global village, as I could call it, when it comes to HIV/AIDS, the global response to HIV/AIDS has been the greatest response that we've had. It's very unprecedented for chronic infection. I think globally, the world came together to be able to manage HIV to the point where we have it now. Africa, except for the gaps that we had for the first decade, and Africa became the epicenter of HIV/AIDS. Since the beginning in '81, we've had 40 million people that have died because of HIV/AIDS, but we also have averted several millions of them. And this is thanks to the global health community that we've had this success. And the success is, now that we see it, we are at the last mile of it, where the new infections are coming down significantly, mortality is coming down significantly. But because we are at the last mile, we have to be very careful with what we do. The next comment that I want to make is about funding and the research, funding, and support that we've had from the international community. The success that we've had with HIV/AIDS globally, and particularly in Africa, which is the epicenter, it's because of the multilateral and bilateral funding that we've received from several countries globally. The UN, the United Nations through the Global Fund, UN, UNICEF, and UN AIDS have been very instrumental. But bilaterally, a lot of countries, the US, Canada, European countries have been extremely supportive in providing the funds and the technical assistance. However, what I want to introduce is that when funding is being done consistently, which it has over the last 30 years, there is an expectation. And the protocol and the parameter that I want to introduce is that it's very, very unethical for a rapid and an abrupt stop in funding for a sensitive disease like we have in HIV/AIDS. And I think it's something that we should be able to, at some point, come that it would require about 12 to 24 months notice for any of the funding should be stopped. And coming from Africa, we're leaving the situation as it is. Thirdly, what I want to say, and probably most important, is that there are 55 sovereign nations in Africa. They call themselves sovereign nations, and I think a new parameter should be introduced, that if you're going to call yourself a sovereign nation, you should be able to at least provide 70% of the support for the health and safety of your population so that you don't become excessively dependent. And I think that's very critical. Now, the fourth thing that I want to say is resurgence. We are at the last mile where we've seen most of the African countries with the epidemic control coming down very gradually with the new infections. But this is very fragile, particularly because we're at the last mile of it and hoping that at 2030, we should break the back of the pandemic so that it does not become a global health major concern like it's been over the last 40 years. And so we have the risk of, if this is not managed carefully, we're going to have the resurgence of HIV/AIDS, particularly in the epicenter, which is in Africa. And like they said, any pandemic all over the world, it's less than 24 hours away from LA, less than 24 hours away from New York. So it's going to be incumbent on all of us to make sure that that is managed properly. Now, having said that, today's presentation, I'm focusing on innovation and epidemic control, which definitely means we want the new infections to keep coming down, much lower than the mortality. And a lot of the African countries are near epidemic control. Quite a good number of them, 6, and I think 5 new ones have been added. It could be up to 11 of them that are exactly at epidemic control. So we're waiting for the next few years to make sure that all of them are under epidemic control. And then we're going to talk about sustainability because we say this is very, very fragile. So join me and I would speak a little bit faster so that I can keep within the time limit. Okay, I just want to acknowledge that the work that we do in Zambia is part of the Global Health Consortium, which is the historically Black universities in the US that have medical schools, which is Charles Drew, where Dr. Lockett is from. And they focus on adolescent and young girls because that's the most vulnerable group that you have, particularly in Africa for HIV/AIDS. And then there's Meharry that deals with the mother and infant pair, because ideally, we should be having zero transmission of HIV from mother to child. And then we have Morehouse that is coming up with telemedicine so that we can reach out people who are in remote areas. Howard University focuses on making sure that we can retain patients in care. So stable patients that are already in care. And for that reason, we have 140,000 patients in Zambia that receive care from Howard University on a daily basis. So we'll quickly just go through making sure that we have everybody on the same page, both the people online and those who are presently here, and just go over HIV/AIDS in Africa and in Zambia so that we can make sure everybody is on the same page. We'll talk about challenges of funding because that is actually very critical at this moment. Importance of the epidemic control that we're talking about, and then we'll talk about the Howard University DSD innovative process that has significantly contributed to Zambia being at epidemic control as we speak, and then some concluding remarks. So this is where Howard University has been working over the last 20 years that I've been in South Africa as the regional director. And take a look at the map and you will see why Howard University has been focusing on Nigeria and the southern and eastern region of Africa. So if you recall very well, it's approximately 40 million people that are still HIV positive in the world, depending on what reference you use. You could see some that are as low as 35 million. Whatever the case, that's still overwhelmingly very high. Africa is the epicenter because if you look at the bottom of it, you can see that Eastern and Southern Africa, it's about 20 million, and West and Central Africa is about 5 point something. So overall, we have about 26 million people that are HIV positive on that continent. And if you remember the graph that I showed you for Howard University work that we're doing, these are 9 African countries that the prevalence of HIV is about 20 million people that are living with HIV. You could see that on the West is Nigeria because of the sheer population of the country, but most of them are in actually Southern and East Africa region. South Africa alone, where I live, has about almost 8 million people that are HIV positive in a population of about 65 million people. Nigeria probably has a population of maybe 200 million or plus, and they have about 2 million people that are HIV positive. Mozambique is a much smaller country with about 2.4 million people. So 9 countries have about 20 million people. But I wanted to make sure that being here at UCLA, let's get the perspective right. Zambia has a population of only 21 million people compared to the US that has about 330 or 350 million people. And you can look at the number of people living with HIV in the 2 countries. Zambia, with a much, much smaller population, has 1.3, and the US has about 1.2 million people. New infections is about the same, which you could see. And then AIDS-related deaths, it's about the same. But look at the 3 last parameters. The number of people who know their HIV status is higher in Zambia than you have in the US. The number of people on antiretroviral treatment is higher than you have in the US. And those that are virally suppressed, which is a very important parameter, it's also much higher in Zambia than you find in the US. So the next slide is saying, we need to ponder over this. Why do you think that is happening? Now, when I teach in the classroom, this is usually a slide that people would debate it for about an hour. We don't have that time here. But I could just tell you that the epidemic in most of the African countries, including Zambia, is a generalized epidemic that is affecting the country economically. People at some point were not being very productive. Life expectancy in the early 2000s was about 40-something years. It's gotten much better. In the US, the prevalence is much higher in the Hispanic and Black population, which normally would have challenges accessing health. So these are some of the reasons which we could have debated if we had enough time. But let's just see what Africa is doing to make sure it's contributing, or globally, what is happening to make sure that HIV/AIDS we can end it as we know it today by 2030. So the United Nations Sustainable Development Goals, goal number 3 is actually targeting to make sure that they can end the epidemics like HIV, TB, and neglected tropical diseases, which again, that's an indictment in Africa that you have a set of diseases called neglected diseases. Neglected by whom? So that's a very big challenge and a call for the African nations which is the reason why I think there should be that parameter that says each sovereign nation must be able to take care of the basics of health of its country. And UNAIDS came up with this target, which all the African countries are working towards this target, to make sure that in your population that is HIV positive, you must ensure that 95% of the people living with HIV know their status. That's very critical. You must find them, test them so that they know their status. And the second one, 95, which has become the Bible of HIV/AIDS management globally, especially in Africa, is to make sure that when you find these people who are HIV positive, 95% of them should be put on treatment. And the third one is that 95% of them must be virally suppressed. You remember the numbers that I showed you for viral suppression for the US and for Zambia? So the African Union is also coming up with what they call Agenda 2063. It's a 50-year agenda for the continent. They also want to make sure that by 2030 they can end AIDS. They've come up with the Africa CDC, which is relatively new. It's probably been in existence for like 10 years. It's going to mimic what the US CDC is doing, but they've also come up with the African Medicine Agency, which is going to be the FDA of the African nation, because most of the drugs, 90-something% of all the medicines in Africa, including the ARVs, are imported. And that begins to tell you about the pricing, that it's very, very expensive. And the other thing to tell you is that about 500,000 people die a year in Africa because of substandard or what you call counterfeit medicines. 500,000 people. So these are some of those countries that before now have been able to meet the 95-95 target that we just spoke about. And I'm saying lately there are about 5 more countries that have met that target. So these are the first 6, 5 more to make it 11. But they're doing very well in meeting these targets. Now, epidemic control, I want to say there are 2 major factors that affect epidemic control. So it's a very fragile state. If you don't have enough funding, or if your funding is cut abruptly, if you don't have enough human resources, which Africa is getting used to it because of brain drain, so we're having task shifting, where the work that physicians were doing, we're passing them down to the nurses, and some of the work that the nurses were doing, we're passing them down even to community health workers, or disease control surveillance officers, we call that in Malawi. And then country stability. These are the 2 points. Again, the conflicts and wars. These are the first 2 points make epidemic control very fragile, to the point where you can have resurgence anytime if these 2 main factors are not in place. Well, infrastructure and all the other activities, we can always work on them, but the first 2 bullet points are very critical. And we see that the first bullet is being threatened right now, which means it threatens ending HIV/AIDS by 2030. So the challenges of funding, so that you can get it. Now, these 6 countries that have are already at epidemic control, you could see that how much funding they're getting from one country, which is the US. Eswatini, which used to be called Swaziland, is getting almost 80% of their funding for HIV/AIDS from the US, from one country. You could see that even countries like Tanzania getting 40 to 50% from one country. So let's talk a little bit more about that, because that's very critical. So you could see that in Africa, there are a couple of countries like Malawi, Mozambique, that almost 90-something% of their HIV/AIDS budget is coming from donor funds. And that's the reason why I made that third point very strongly, that the African countries have a role to play, and they must play it if they want to be called a sovereign nation. You have to be able to take care of your population. And so you could see the picture here that there are just a few countries like South Africa and perhaps Angola that are receiving over just about 50% or, from as donor funding. And South Africa probably for donor funding much less than 50%, which is excellent. Now, let's look at how HIV/AIDS management is affected on the continent so that you can begin to understand this. These countries, this is how much is being spent a year in dollars for each HIV patient that is positive on the continent. Now, we have about 32 ARVs that are registered in the US. We can't afford that in Africa. So if a patient fails first line, second line, we don't have the luxury of third line, fourth line like you may have in the US. So that's very, very challenging because these drugs are still costly in Africa, especially the newer drugs that are coming into the market. Several negotiations have to be made because none of these drugs is manufactured in Africa. So in the US, you could have $40,000 being spent on an HIV patient, 40 to 50 actually. But the highest you find out is it's roughly about $300 to $400 a year. That's how much is spent on each HIV patient in Africa. So the US again, you could see not just the US and Global Fund. You can see this is procurement of ARVs on the continent. Majority of it comes from the US, 32%, and another 50% from Global Fund. So most of it is donor fund. So how has the stop work order in the US affected the continent? Severely. And you could see that. The mortality is going up because we had said the epidemic control is a very fragile state if you don't maintain it. And so when we talk about mortality is going up, it sounds very statistical. I want to interpret it and break it down to say people are dying because of the stop work order, because of the immediate shutdown of funding. And when we say people are dying, it's an underestimate. A lot of people that are HIV positive in Africa are actually breadwinners for their families. And so when these people pass on, the repercussions and the ripple effect is very, very severe. These are usually not captured. And so in our program in Malawi, where we're collaborating with CDU, the funding cut, even for a month, you already could see the effects that HIV testing services and ART and viral monitoring services had stopped in some of the areas. Community health services had stopped in a lot of the areas. In Zambia and Howard University, we had designed a program on proactive appointment system, which is a system that is running through the 30 high volume facilities that we're taking care of, and that had to come to a stop temporarily. We'd resumed it, but you could see the effects of it. And if it goes longer than 2-3 months, people are gonna die. That's simply what it means. We'll talk about this later, all of these parameters that are affected. But epidemic control and transition for sustainability. Now, HIV/AIDS on the continent is mostly managed by implementing partners. We give credit to each African country. They have the patients, they have the infrastructure, but a lot of the technical support and technical work is actually done through the implementing partners, which we think that dynamic, we need to revise it so that it becomes a true partnership so that we can have sustainability going forward. So epidemic control, what we're looking at is the incidence to mortality ratio and making sure that 73% of viral loads, at least 73% of viral load. That's the general definition. Now, for you to be at epidemic control, it means your new infections and deaths are low and declining, and the global target for people virally suppressed, which is 73%. But we have this higher viral load that we're looking at in terms of the UNH goal. Near epidemic control, which is where you find a lot of African countries, and that's why we are at the last mile, to make sure that we can push everybody who is near epidemic control to be at epidemic control. New infections and deaths are low and declining, but the global target for people virally suppressed has not been reached. So it's not even reached generally the 73% that we're talking about. And you could see that in the US, viral suppression is lower than you find in a lot of African countries. So there are people who are not near epidemic control. Now, I also mentioned that transition and sustainability becomes very critical because there are a lot of implementing partners, as soon as the funding runs out, they drop everything and everything is reversed. So we must, and we're holding African governments to start ensuring that they work with implementing partners to make sure that there's sustainability, which is exactly what Howard University is doing in all the countries where we're working. We've seen this already, but just to emphasize on it, that 95-95 is what the African countries are all working with at the moment. And so in Zambia, the first 95 were at 98%, which they've done exceptionally well. And I think as Howard University, as implementing partners, CDU and all the other implementing partners have collaborated very well with the government to make sure that the first 95, which is knowing your HIV status, is at 98%. And the second one, which is putting people on treatment, they're at 98%, and being virally suppressed at 95%. So this is excellent. And however, we've said this is fragile, because if the funding doesn't continue to roll, all of this is going to reverse in a short time. So that's the graph that you have for Zambia. You could see the number of new infections coming down very nicely. This is what we want to see leading to 2030. If we have this for every African country, then our 2030 is going to be a reality. But if it's interrupted by funding, as we're seeing in some of the countries, then this is going to be a mess at the end of the day. So I'm very happy to see that a number of people that are introducing the parameter of sustainability, and because it's very critical to talk about sustainability. Just look at the bottom of it. South Africa has a sustainability score of 10, but they are not at epidemic control. But that could be because of the sheer numbers of HIV positive individuals. South Africa has the highest in the world, 8 million people that are HIV positive. But you can look at a country like Ethiopia that has less than 1 million people that are HIV positive. Their sustainability is 1. This could be because of some of the conflicts, some of the other activities that we're having. So this is a good parameter that the ministries of health should be aware of and be able to make sure that every implementing partner, Zambia is at sustainability of 5. That is still very low. And so the government needs to work harder on that. Now, just in terms of what are the activities to make sure that you're at epidemic control, you want to scale up index testing, which is something that we do very well. We have a cohort of about 140,000 people. So through those people in our cohort, we want to go back to their families and be able to ask if we could test all the people in the household. That's what we call index testing. And that is working very, very well. We usually don't get 100% because some people are going to say no, but it's been very, very effective for us. PrEP, which is what everybody is familiar with, especially with the long injectables. Now, task shifting, it's going to continue to be critical. When I give this lecture in the classroom, in the next 50 years, we'll never have enough physicians, never have enough nurses, not enough pharmacists. So we need to stop moaning about it in Africa and figure out a way. HIV/AIDS management came up with a very good approach. We have to do task shifting, and we've worked very, very well with task shifting. Although some of the people complain that you shift the task, but you don't shift the salary. But engagement of the community. This is very critical because it's never happened in many in the past. We now give 6 months worth of treatment for the patient to take to the community. So patients actually take these medications in the community. And if you're only waiting for them to come back, because we see them for clinical assessment every 6 months. So if you're only going to wait for 6 months, a lot of things can happen in 6 months. So how do we begin to engage them at the level of the community? So there are different approaches, and I will show you one of them that we're doing. So there are a number of activities here, including the differentiated service delivery, which is what Howard University is actually applying. Now, what is differentiated service delivery? It's a terminology that WHO came up with it. It just means one size does not fit all. And with HIV/AIDS, particularly when we went to universal treatment meant everybody was HIV positive, you put them on treatment. Before we were staging at CD4, started off CD4 less than 200, CD4 less than 500. As soon as they said everybody was positive, they clogged all the healthcare facilities, the clinics, the hospitals. So how do we unclog it? Because it was impossible to manage the patients. And that's what we're calling differentiated service delivery, where we're looking at the specific needs, customizing it to the patients and to the healthcare system. And that's exactly what we've done. So it is client-centered, and it's also health system efficient. And the results that Howard University is reporting from Zambia is that even the employees are very satisfied. The patients are very satisfied, and we're getting excellent results, which I will share with you in a minute. So in Zambia, we're working in 3 high-burden provinces and 30 high-burden facilities. That's why we have about 140 patients. And for those of you who know a little bit about Zambia, the Copper Belt area is where they do the mining, and so there's high HIV prevalence in that state. The southern province is a border town, and so all the border towns that you have in Africa, because of the truck drivers crossing, HIV prevalence is very high in those areas. And Lusaka is the urban area where you have a lot of HIV in all the urban areas in Africa. So when we started this work, the retention, which is the biggest problem that you have with a chronic disease, particularly in Africa, how do you get the patients to keep coming back to the facilities? Now, the retention in some facilities is as low as 40%. The average was about 60%, which means you initiate patients on treatment and you don't know where they've gone to. They're not coming back. You don't know how to get in touch with them. Some of them don't have cell phones. So what does that mean? You're just breeding resistance. And so that's a very critical thing in Africa, to make sure that you have the retention. How do you keep track of the patients? Now, you have to do this community extension that I'm talking about, have community health workers that are tracking the patients at the level of the community so that they can come back. You would see what we did, taking retention from 60% to 98%, and which is excellent. Linkage to care, because some of the patients that came and they had a CD4 count of 600, 700, they were asked to go back home because at that time, it was not universal treatment. We had to look for them, to ask them to come back to the facility because you can now initiate them on treatment. A lot of stockouts, monitoring adverse drug reactions, and many patients stopped taking their medications because of the adverse drug reactions. When we did our baseline, there were zero to very few adverse drug reactions that were reported to the regulatory authority. And you would see that we now have thousands of them being reported, and 94% of them come from Howard University alone. And then we spoke about the healthcare worker shortages and no adequate training. Viral load suppression was a mess because they had a problem with documentation, recording. It's still there, but it has improved tremendously in the 30 sites where we're managing the patients. So DSD, what we did, and our objectives was, number one, to reduce the congestion and waiting time. Because if you went to any of those facilities in the morning, you would think that, there's no space. People start coming about 4 a.m., 5 a.m. We had to figure out a way to manage that, and we did very successfully. Improve adherence. We introduced a concept called concordance, which meant we have to agree with the patients. And these are typical patients that you see some of them, a majority of our patients selling in the market, they make about $40 to $50 a month. That's, some of them make even less than that. So when we talk about patients, some of the patients in Zambia that we're taking care of, those are the patients that we mean. So missing one day of being in the market means a lot to them. So if you're going to make them wait for 4 hours, 6 hours online, they're not just going to do that. That's why the retention was very, very low. So we want to make sure that viral load suppression is critical, because the patients that are virally suppressed are the patients that would not transmit. So that's how you can break the back of this. And we did 98% viral suppression. When we came in, it was about 73%. So adverse drug reactions, we've spoken about it. So what we also did, because you're going to be seeing 95, 95, 95, Howard University added another 95 to it. So we at Howard have 4 95s. Now, the first 95 in the UN AIDS is to make sure that you know your HIV status. What we also did was a 95-0, which means we are focusing on prevention. We want to make sure that most of the HIV patients in Africa die because of TB. We wanted to make sure that those who are 95% of those who are eligible for TB should be initiated on treatment, on TB prophylaxis. We also do HIV education through our community workers. We give out condoms. So we need to make sure that the prevention is going on. And then a number of things that we do for testing and treatment. Again, we want to make sure that the patients don't wait online for too long, because they're not going to wait. They're just going to come at maybe 5 a.m. and if it's 8 a.m. or 9 a.m., you're still on the line, they just go, and you may never find them. And then in terms of the last 95, we want to make sure that they're taking their medications on time. We send our community workers to do reminders, and that's how come we're having all the results that we've had. In a typical facility in Zambia, you have to go through these 6 steps. And these 6 steps is the reason why patients were waiting for so long, because each one of them, you have a queue. So what we did is that this is a typical facility. The red areas is where the patients would queue. And so you would queue at number 1, and then you queue number 2. So what we did was work with the facility and the Ministry of Health to consolidate this and using a prefab. So all your HIV needs, including dispensing, clinical assessment, phlebotomy, everything is done in the blue building. And because of that, we therefore had a one-stop shop. And that reduced the time significantly from 6 hours to less than an hour now. We're actually running at about 45 minutes. So because of that, all our healthcare workers at the end of the day, they will meet as a multidisciplinary team to go over the day's work. What is it? Where should we lay emphasis? Where are some areas of improvement? Did they see a patient that was atypical that they needed to address particular things? So based on that, in 2024, we're beginning to offload some of the sites that we think are ready for transition. And transition should be, for sustainability, should be planned on day 1. And that's very important, that as you, in the program inception, transition should be discussed at that time. And so we're beginning to transition some of the sites to the Ministry of Health. We just monitor them remotely or virtually. You could see that in this number of patients, 80% of them enroll in our DSD program out of the number of facilities that we have, out of 166,000 patients. But documented viral load is where we still struggle a little bit, because some of them are, because there's inconsistent power supply in Zambia. And so what we do is documentation is very poor. We're helping with that. However, those that are documented, they're 99% virally suppressed. And I think we usually pat ourselves on the back, because this is the most important parameter that you want. And so this is just showing what happened when we got to Zambia. And we did 6 hours waiting for clinical assessment, 4 hours waiting to pick up medications, and we brought that down significantly. Also, the appointments. People who missed appointments, this was in 2018. People who were missing appointments, this was in 4 facilities. There were about 200 and something people that would miss the appointments for more than 7 days, and that's very dangerous for HIV/AIDS. And so you could see with the interventions that we had, community health workers, reminder calls, it came down gradually. By 2019, we're at 5. And now, usually we have 0, because our community health workers would look for you because they live in the community. And so that was the waiting time. We cut down the waiting time to generally about 45 minutes. From 6 hours that you were doing clinical assessment, we're down to 45 minutes. And what we also did with retention, you could see what I said, when we got the retention was 60%. We did retention in 6 months, in 12 months, and in 24 months. 24 months retention is what you should ask every facility. What is your 24 months retention? You'll be very surprised that some facilities have it at 40%. But at Howard University, with the interventions, community health workers, our retention at 24 months is 95%. And that's not because 5% sometimes are unaccounted for because the patient may have moved to another country, to another region, they don't have a cell phone. And so the true percentage should be something between probably about 98%. The index testing is what we do. We have this cohort of 140,000 patients that we do. We always check with them to see if we can test members of their household. I think this is just a sample of it in 2025 that we did. And you could see that a lot of them all of them accepted. So which means giving access to members of their household, which it could be multiple people in their household. And you could see that on the last bar, it's showing that out of the 437, 134 refused to be tested, which is up to them, but we'll keep trying. 256 tested negative. 54 of them retested and then told us that they knew that they were positive. They were just retesting again. And then the yield was very low, which is very impressive. And this could give credit to some of the retention, the virally suppressed that we have in that household. We also do cervical cancer screening because our DSD program is a DSD plus. We do cervical cancer screening. Usually we identify the women, we refer them to labs where they do cervical cancer. And what we haven't done is we're not doing prostate yet, and that's what we're going to be adding this year to make sure that for the men, we're also doing prostate cancer screening. Now, quality assurance. Here, I want to introduce pharmacovigilance because a lot of patients that you have would stop taking their treatment because of the adverse drug reactions that they have, many of the patients. So what we've been able to introduce in Zambia is what you call community-based, patient-centered, community facility-based integrated pharmacovigilance. So majority of our adverse drug reactions are reported by our community health workers because we've trained them on the basics. They have a tool. When they contact the patient on a weekly basis, they always ask basic questions. What are you feeling? And so that when we review that, some of the patients, if somebody had a Stevens-Johnson syndrome, it means we're going to tell them to come in immediately. Otherwise, because you gave them medications and they're on it for 6 months and you will not see them after 6 months, this is the only way we keep tab of the patient. So we now have what is called community-based pharmacovigilance. And through community-based pharmacovigilance, we have most of our adverse drug reactions. You could see that from about 5 adverse drug reactions, sometimes 10 that were reported to the regulatory authority. We're now at about 12,000 over the years that we've been working in Zambia, and 95% of adverse drug reactions come to the regulatory authority through Howard University. So that's something that we want to expand and train other implementing partners to be able to document in this manner. So these are just talking about the cases that are being reported. And you can see that in 2025, the cases, January and February, the cases are going down of adverse drug reaction. You could guess why. Because of the stop order. So a lot of the people who were supposed to be going to work and documenting this couldn't with the stop order. So this is the kind of thing that you see happen, which we've spoken about it, but also spoken about what each and every African country has to do for itself. So this is just giving you the details of what we mean by community-based pharmacovigilance. This is something that is generally new because a lot of adverse drug reaction documentation is done at the level of the clinic. Now we're beginning to do ours at the level of the community. Now, remind you that these are signal generations. We have to do some kind of, the multidisciplinary team does a causality assessment to be able to know if this is drug related and if this is severe, if this is mild or moderate, which is a terminology that the World Health Organization has introduced to classify adverse drug reactions. If we get severe adverse drug reactions, they're usually referred and engage the infectious disease specialists and a number of other specialists. And a lot of times we also work with Howard University Hospital when we have very difficult, severe cases. Howard University Hospital is brought in to be able to review these cases. Now, this is new, something that Howard is recently introduced because in Africa, that is the home for substandard and falsified medications, for counterfeit medications, including ARVs. There are a lot of ARVs that are floating on the continent that are counterfeit, and they come from Pakistan, from India, from a lot of other countries that are counterfeit medications. And people have tried to introduce the concept of barcodes, but the people who make counterfeit, because it's a multi-billion-dollar industry, they know how to circumvent barcodes. But what they cannot circumvent is what we're trying to introduce. That this time around, we want people to report therapeutic failure. If your viral load begins to go up, we'll have to report it. And the quality of the product. We're asking the community health workers to talk to the patients and pay attention to capsules that are sticky. We're talking about suspensions that are discoloration with suspensions, because it's unacceptable that 500,000 people die a year on the continent because of counterfeit medicine. So these are some of the things that we are introducing and hoping that there's going to be continuation of funding in some manner so we can do this. So I hope we were doing very well with time. So I just want to be able to summarize by saying a few things. We want to ensure epidemic control because we are at the last mile. So what is it that we can make sure that we are at epidemic control in all the African countries? If we have to meet the 2030 deadline that we're talking about, to make sure that HIV/AIDS is no longer the public health threat that we have now, is to customize interventions, such as the DSD program that we have. It's very, very critical. Most often it's one size fits all on the continent, and that's not going to work if we have to break down this. We need to make sure that we're integrating HIV and non-communicable diseases. There are some funders that fund specifically just HIV, and when the implementing partner wants to do integration, they say no. And I think that's unacceptable. I don't think any country or Ministry of Health should be accepting such an intervention. So we have a lot of diabetes on the continent, hypertension, cancer is on the rise on the continent. This must be integrated with HIV/AIDS management. So we need to introduce frequent patient satisfaction surveys. People assume that because you're poor, you should just accept whatever we give you and you go home. No, in our program, we do frequent patient satisfaction surveys. And we also do employee surveys to make sure that our DSD program is meeting both ends of it. And introduce interventions to prevent loss to follow up. A lot of countries have a program called loss to follow up, which means the patient gets lost and you start looking for them. What we've introduced at Howard University is prevention of loss to follow up. We don't want you to get lost and we start looking for you. So our community health workers are in touch with you every week. Community health workers are volunteers. It's a category of healthcare workers in Zambia called volunteers, and they get paid a stipend. And so at the facility, Howard University engages them, assigns a number of patients to you, and you're able to reach out to them on a weekly basis to find out, make appointments, do you have any adverse drug reactions, get convenient appointment system for you. And we had an appointment system that was designed in Zambia, which says, if you agree with us that you're gonna come on Wednesday at 2 o'clock and you're there at 2 o'clock, you would be served first. And you sit on a green bench. And if you come on Wednesday, but at the wrong time, you sit on a yellow bench. We'll get to you, but you're not priority because there are people who came on time. And if you come on a completely wrong day, which some people do that, you sit on a red bench and we'll get to you, but a little bit longer. So that incentive has made everybody wants to come exactly on time They want to spend just 40 minutes, 30 minutes, and they go. So in all our facilities, it's the benches are coded. So the other thing that has been happening is that because HIV prevalence was very prevalent in the female population, we've been focusing on the females, and now we're beginning to see it arise in men. And a lot of times the men in Africa are those that are working, driving the trucks, and they're never available. So what we did was we made Saturdays and Sundays available, extended evening hours, and you should come to those extended evening hours or the weekends. 70% of the clients that we have are men. Then you could know that during the week, you cannot work well with them. So we've spoken about engaging the community. Now, sustainability that we've spoken about is what I just spoke about in terms of the African countries that call themselves the sovereign nations and cannot take care of their patient, the health of their patient. There was an Abuja declaration in 2001 where all the African countries signed to it and said they were going to provide 15% of their national budget to health. Now, very few of them, up to, this is 2001 to now is so many years, 24 years ago, very few of them are up to 5%. So this is unacceptable for sustainability purposes. And so that's what we're encouraging, that we need to revisit that. It was signed by all the African countries. Foreign aid should actually be considered as supplemental. And I think that's what we should be pushing for African countries to be able to do. Or during emergency purposes. We have cyclones in Mozambique all the time, affects HIV/AIDS patients. Yes, we could make sure that we quickly deploy funds from everywhere for that. But routine practice, we think 75% of them, I think so, should actually come from the country. Engagement of all stakeholders. We've spoken about the long-acting vaccines. So the number of things that re-engineering of healthcare facilities. Now, a lot of the healthcare facilities that we have in Zambia were built during the colonial days. So they are now attending to a catchment that is about 20 times what the facility was originally meant for. And so that makes it very, very challenging. And so the re-engineering and infrastructure upgrade must take place in these African countries. And lastly, I want to talk about something that I'm introducing newly. This is self-reliance beyond sustainability, because we are going to talk about sustainability between now and 2030, which is about 5 years. What happens after that? Because we've talked about epidemic control being very fragile. You could have resurgence if it's not properly maintained. So what should we be doing after that? The onus is going to be on the African countries. And we're challenging the African countries to be able to work. African countries have academic institutions, research organizations that need to partner with the US organizations and globally to be able to get perhaps a vaccine, like the HPV vaccine that we give children at the age of 9, 10. Acceptability is one of the things. Yeah, we can deal with that, but we need our African scientists to come to the table to be able to work on the elusive HIV vaccine that we can then give it at before early sexual debut. And we could deal with the cultural aspect of it through education. We had that problem during COVID. The COVID vaccine hesitancy was extremely high in Africa, and it wasn't reported accurately. Most of the African countries, it was very high. So that's something that we'll have to continue dealing with it. But this is something that I think we should be able to look at. We should start talking about it now, beyond sustainability, which is self-reliance of the African countries. I think this was my last slide, and I'm not sure how well we did with the time. Very good. All right, thank you, Arena.
Thank you, Dr.